So I'm going to talk now about common trial designs. And as I said before, phase 2B and phase 3. Why? Because these are controlled and they're randomized. Phase 2B tends to be smaller in size. Phase 3 tends to be larger in size. We'll talk about this terminology, and that's from the pharma business. But one thing I want to reiterate is that the interventions that we can use and compare or test their effectiveness can be any type of intervention. They can be a behavioral educational intervention. They can be, physical activity. They can be holistic medicine, like Tibetan medicine, for example. They can be Ayurvedic. They can be homeopathic. They can be physical therapy. They can be any kind of things, right? And so the crucial thing is to have a comparison. The standard one is what we call the parallel design. Why? Because the two interventions are being given at the same time in parallel. And this is one of the specific design issues, and that is that you are interested in studying people with a particular condition. However, given your eligibility criteria and your exclusion criteria, as we said earlier, you homogenize, reduce the variability in that group. Why? Just to be able to get the result of the effectiveness of your intervention without having too much noise in the system. If you have people that are very different, you have a lot of heterogeneity, a lot of noise. You are all medical people, but engineers think about signal to noise ratio. And if your signal is high, meaning your intervention is effective, even if you have a lot of noise, a lot of variability, you will be able to see and detect that signal. But many times, our signals are not that big. They're small effects. And if the small is the effect, if you have a lot of noise, you won't detect it. It may be an important signal, but it's a small important signal. And you want to be able to detect it. So if you reduce the noise, you may be able to detect a smaller signal. So you homogenize people by eliminating some of that heterogeneity. But because we're dealing with humans, you have to go through this consent process. They're volunteering. You can't get people that say you're randomized, so now you have to do this. You have to get them to consent. And we follow people, intervention A and B, until you get your event of interest or your variable of interest. This is the basic design of almost every trial. So the two-arm parallel design done concurrently is that. Sometimes we do 3 arms. Here's an example of 2 Siddha polyherbal decoctions. I'm not going to say the names, along with standard allopathy treatment in the management of mild to moderate symptomatic COVID. It was double-blind, placebo-controlled clinical trial. So they had arm 1 was the placebo plus the standard allopathy treatment. Now they had this polyherbal decoction, Nilavembu Kudanir, and then Kaba Sura Kudanir, added to the standard allopathy one. So the standard of care would be the standard allopathy, and now they're trying to see what happens. So again, now we have 3 arms, parallel, and we see what happens. So people do more than 2 arms. If you do more than 2 arms, you have to say, well, what are you comparing? You're comparing this to this, this to this, or are you comparing between these 2? And if you're comparing between those, all 3 of those, then you have to have adequate sample size to deal with these different comparisons and the fact that these comparisons are not independent from each other. Because I'm comparing this to this and this to this, well, that comparison of those 2 is related to the one between these 2. So it becomes a little bit more complicated if you have more than two comparisons. Now, many times we have a little bit more complex design. Why would we have a complex design? Well, for multiple reasons. One of those multiple reasons is because we may be difficult to recruit some people because they may think that the intervention A in their mind is better than intervention B. Now, one of the things that we have to say, and I may not have it in my slides, is that whenever I start a trial, we have to have a condition that is ethically driven, and it comes from the French word equipoise. And equi is equal, and poise is position, meaning that A and B must be equally positioned. Because if they're not, it means that one is better than the other. And if one is better than the other one is inferior to one. So it's unethical to do a trial where one is inferior to the other. And so, but equipoise is something you say, wait a second, no, I have a new treatment, I think it's better. They're not equally positioned. Yeah, they may not be equally positioned in your mind, but they're equally positioned in the clinical community's mind until you show the evidence that one is better. So equipoise doesn't have to be you necessarily. It has to be whoever would be using this for treating people with that condition. If it's not, there is ambiguity, there is uncertainty, there is not really a evidence enough that everybody is convinced that this is better, then it's okay to do a trial. Now, it could be that your participants may think, oh, I want to get A because A is better. And well, if they want to do that, they may not want to, you may not be able to recruit enough people into your trial because everybody wants A. And you say, no. You have to be equally happy when if you get randomized to B or to A. And they'll say, no, then I don't want to do it. But they won't do it. And so one way to convince them is say, okay, everybody is going to get A. You will get A. But you will get A maybe first you get B, we see what happens, and then we'll give you A and see what happens. So you will get A. And here these people will get A first, and then they'll get B later. So everybody gets A and everybody gets B. That's one attraction in recruiting. Second attraction is, suppose I randomize 1,000 people. So I have 500 go to A, 500 go to B, and then these people go to, these 500 go to B, and these 500 go to A. So now at the end of the study, I have 1,000 people got A and 1,000 people got B. So therefore, I've doubled my sample size. Wow, this is fantastic. Let's do this all the time. Well, there's a problem here. The problem is that whatever you're studying, multiple problems. First of all, after you've observed this stage, people have to go back to whatever stage they were in here to be back at the original stage at which they started. We have that period of washout. So that the washout means that whatever effect this had needs to be gone by the time you start the next one. And whatever effect this had, it has to be gone before you start the next one. Well, that's not always possible. If I've taught them how to do exercise, now I can say you have to forget that exercise and start this other one. If I'm looking at time to death, once they're dead, I cannot bring them back to life and see when they die again. If I'm studying a chronic disease and I have to wait 5 years to see cancer remission, then now my study is lasting 10 years. So it's not always possible to do this kind of stuff. In fact, it's almost very few times possible to do it. It's done a lot, for example, in hypertension, because you give them, if you give somebody a drug to lower their blood pressure, it works while they're taking the blood pressure lowering medication. Once you stop it, they go back to their blood pressure going back up. So then they go back to their original state, right? So that's, sometimes you can do that. And it's convenient because you can recruit people, and you can get more cases this way, more participants. So here are the limitations that they may last longer. You have the carryover effects, and you have to have this washout period. But it helps recruitment, and you will get larger sample sizes. So by the way, since you have all the slides, some of this stuff I'm not going to read it. You'll understand it. Now sometimes you can't do all of this crossover, and we may do what's called a incomplete crossover. And why do we may do it? Well, if I want to recruit people and say, everybody, you want to get A, because nobody wants to get placebo, so okay, everybody's going to get A, but some people are going to get placebo first, and then you'll get A. And so we don't give placebo after we've given A. So it's not a true crossover. It's called an incomplete crossover. And so this is just to help with recruitment, not to increase efficiency. So everybody okay with crossover? So crossovers are not as common. What is more common is a factorial design. And a factorial design is one where you, as investigator, are thinking about two different types of treatments, and you want to see if do two studies in one. I want to study factor A and factor B. And so I can give A or not give A, and to a bunch of people. Let's say I have 400 people, so I can give 200 people not A, and 200 people give them A, and this would be a comparison of the effect of A. Or I can test B in the same 400 people, and some 200 of them will not get B, and 200 of them will get B, and I can test whether B is effective or not. So I'll get 100, 100, 100, and 100. So it's attractive because now I can study two different types of interventions at the same time with the same 400 people and answer both of those with 200, 400 each. But again, there is no free lunch. There is a problem here, right? What could be the problem? First of all, this is equivalent to doing a 4-arm parallel, because there's some people that don't get anything, no, the no, yes, the yes, no, and the yes, yes. Okay, so it's nothing but that. And the big issue is what we call interaction. And interaction is not talking to each other. Interaction is a technical term in statistics that means that the effect of one intervention depends on whether you are receiving or not receiving the other intervention. So the effect of A may depend on whether you get in B or not B, or the effect of B may depend on whether you get in A or not A. So that's, some people call it synergistic effect. We call it interaction, okay? If you have no interaction, then the effect of A doesn't depend whether you get in B or A. Then you can look at these 200 and 200, and you can look at these 200 and 200. So you get two studies for the price of one. If there is interaction, though, now you have to look at the effect of A when you're getting B, and you have to look at the effect of A when you're not getting B, and you have to look at the effect of B when you're not getting A, and the effect of B when you are getting A. So now you have to do two for the price of two. And so you have to get enough numbers. So you don't get the benefit of answering two questions with the same sample size if there is interaction. On the other hand, some people say, but I'm actually interested if there is interaction. Why? Because it could be, let's say this is some drug, some medication, and this is some educational campaign. oh, is the effect of the drug better when you're educated? Yeah. Or is not as good if you're not educated? Then we call that a synergistic effect. That it's better if you get this than if you don't get it. That's an interaction. And you may be interested in studying interactions. So these factorial designs are extremely good at studying interaction. So the advantage is in the absence of interactions, you increase the efficiency, and it's the only trial design that permits studying interaction. Because to study an interaction, you need to study them administered at the same time. Okay. Limitations is that they must have different modalities of action. Why? Because if I give factor A is one drug and factor B is another drug, let's say for hypertension, I cannot give you two drugs for hypertension because they may interact with each other and it would be bad clinically for the person. That's one of the things. So they also need to be able to be administered jointly without modification, without cumulative adverse effects. So if there are different types of drugs, but they have adverse effects that are bad, like you, I don't know, you get nausea and vomiting and you get GI problems, maybe getting the persons that get yes, yes, will have so much bad things, the ethical committee will say, no, you can't do that. You can't give those two things together. It also should be ethical to administer the no-no. If you're studying people with a certain condition that is bad, not giving one intervention, suppose they're now doing controls that are like placebos, you must be able to ethically give nothing to these people. So again, an ethics committee may say, no, you can't do that. You've got to give them something. So it's hard to do sometimes. There should be an interest in studying the interaction of the two interventions. So here's a study that was looking at aspirin and vitamin E. So it's low dose aspirin. This is the baby aspirin. So this was 100 milligram enteric coated aspirin a day. And vitamin E at 300 milligrams also a day. Or no vitamin E or no aspirin. So it was true 2x2 factorial. And so they followed a 2x2 design. It's published in the Lancet. And what did they do? In their analysis, they give us the result of the aspirin versus no aspirin using all the 4,500 or so people. And then they also do for vitamin E versus no vitamin E, all the 4,500 people. What is wrong with this one? Is there anything wrong with this analysis? Now I'm going to ask you a question. Any volunteer to answer? If not, we will go systematically, not randomly, and I will choose one of you to answer. What? So they are doing both analysis, yeah? But I didn't understand what you said. They did not? Oh, the combination group, yeah. So they should have checked if there was interaction first. And they didn't check. I looked at the paper, they didn't check on that. So if you get aspirin and vitamin E, or if you get aspirin and not get vitamin E, you get a different result, they should have checked that first. And there is a test for interaction in what can do. So this is just a warning. Even papers published in the Lancet don't have always are perfect. Even papers published in the New England Journal also have problems. Maybe less problems, but they may have problems as well. So they didn't check for interaction. Oh, that's right, because you have the slides, so you have already the answer. So sorry about that. All right, here's another one. Then this one I actually participated in, was a colleague of mine who worked on this, Dr. Vanderhorst, and he did. This was a study of HIV, and this was before it was known what to do on to prevent mother-to-child transmission of HIV during breastfeeding. Nowadays, we know. And so at that time was, yes, you give antiretrovirals to the mother while she's pregnant, but once she gives birth, do you continue doing it to prevent mother-to-child transmission? So there was equipoise, there was no information at the time. So they said, okay, we don't give antiretrovirals to anybody, or we give it to the baby, or we give it to the mother. And the problem that they had was that in Malawi, where they were studying these women, they were all very poor women, and they were also malnourished women. And so they said we should give them a nutritional supplement as well, because that it helped. They were interested in the synergistic effects. They wanted to know, if we give a nutritional supplement, does it actually help the mothers to have lower transmission to it, to their baby? And a side note is they had trouble with this because the mothers were malnourished because they were poor. So the whole family is poor. You give them a nutritional supplement, what happens? Mothers will give it to other kids in the household, or worse, in this situation, their husbands would take it away from them and take it themselves. Right? So they ended up having to relabel the packet and not call it nutritional supplement, but they call it study medication, so that the mothers would take it themselves. But anyway, it showed this. So they were interested in synergistic effects. And this is how they did the analysis controlling by strata of that, because they were interested in the synergistic effects. So the stratification allowed them to do it. All right. So in the presence of interaction, then you have to do multiple different hypotheses, as I said. And you have, you can compare this one, you can compare this one, you can compare that one, you can compare that one. Whenever you do multiple hypotheses, you need to adjust your analysis for having done that. So that's another complication in the presence of an interaction. Here's one that was done at our institute in Canada that is called the HOPE-3 study. And it's a 2x2 factorial for blood pressure lowering medications, candesartan plus hydrochlorothiazide, HCTZ, and cholesterol lowering medication, rosuvastatin. So it's a 2x2 factorial. So they have rosuvastatin versus and placebo versus candesartan and HCTZ versus placebo. And so they had these 2x2 cell here. And there was no significant interaction between the two treatments. And so therefore they were able to publish two separate papers. So here they looked at the cholesterol lowering in one paper. They looked at the pressure lowering in another. And this is what every investigator hopes in a 2x2 factorial. You don't get interaction, so I can do two papers and get two for the price of one. And this was a large enough study with over 12,000 people. So they got it in the New England Journal of Medicine. This was done in 2016, 2009 or something. Despite no interaction, they also decided to torture the data a little more and look at if there is another result. And so they looked at the combination of each intervention versus double placebo. So now they compare these things, this versus this, this versus this, and this versus this. And again, here, they show that versus placebo, the relative risk is still higher, but it's better for rosuvastatin, and the combo are very similar to each other versus placebo versus the candesartan plus HCTZ versus placebo. So they got their two papers. They decided to get a third paper, and they tortured the data a little more and didn't correct for things here. So be careful at what people do anyway. Now, these 2x2 factorial designs are rarely more complicated than that, or we don't do more than 2 factors. But the design historically was created by the father of modern statistics, or Ronald Fisher, back in 1918, 1920, working with plants, not with people, where he was working at an agricultural experiment station, looking at different strains of barley or wheat or oats, all of these grains that are used for making beer. And he was in charge of figuring out which strain is better, A or B, or this or that. And he said, but wait a second, we have to have other factors. Fertilizer A or fertilizer B, water amount this, water amount that, sunlight this, sunlight that. So he had up to K factors. So he did all these 2 to the K experimental designs. So rarely we do that because it's uncommon to have so many factors and be able to get all of these little control things in studies. The only one I've seen is one that, again, we did, which was the TIPS 3 study, where they were taking people and randomizing to vitamin D, active or placebo, aspirin, active or placebo, and the polycap or polypill, active or placebo. And this was just published in the American Heart Journal, and it showed that it was not statistically significant, except for one of those studies, and Dr. Prem Pais from Ames was involved with that. But it was, they had the design of this and showed that it did work. It was marginally significant. And later on in the meta-analysis, they showed that the polycap was very good. But again, the 2 to the K factorial designs are rarely done. So you have multiple possibilities of reporting when you do that, because you could, assuming no interaction, you can report all of those, and that's what they did. They looked at, this was I can't see it now, it's hard to tell. I think it's this is the polypill versus placebo. This is the aspirin versus placebo. And then this was then here they did placebo and polypill together. And so the vitamin D did not show anything at all. So they didn't report that. But so this is one of the important studies that came out with a 2 to the 3 factorial design. One of I kept digging to see if I could find something, and there was a 2x2 by 2x2, the 2 to the 4 factorial, done by the Physicians' Health Study, that was looking at vitamin C, vitamin E, beta carotene, and then they did, and then the other one was Milvexian, I think it was, some other drug as well. So they do a lot of them, but it's pretty rare to do this. Why? Because in the presence of interactions, now you have to study what is the effect of vitamin C, of Milvexian when you have vitamin C and you have vitamin E and you have beta carotene. Then you have to study this, and you have to study this, and you have to have enough numbers in each one of them if you have interaction. So it's not that commonly done, but it's possible. So if you do a factorial, which is very not uncommon, you need to ensure that you have sample size for each intervention. Maybe for different interventions, you need different sample size, so you should consider the possible interaction and the power. Then also it becomes a little bit more complicated because, taking pills may lead to more adverse effects and may get people unblinded. So then you get potential of unblinding that may occur. And you may have different lack of adherence to them. And then first, you should always, in your analysis, look at interaction. And whether it's statistically significant or not should not be the issue, is whether it's a meaningful interaction or not. right? Because if you don't have the adequate sample size to test interaction, then it'll say that there you don't have an interaction. But that's not the case. The question is whether there is a meaningful one. If meaningful, then you have to report the conditional effects. And if not meaningful, then you get the two RCTs in one. Now, how many of you have seen factorial designs or have thought about doing factorial designs? Nobody has seen them before? Few people. So you're thinking about doing them. So this is a very useful thing to do. But also you have to do it with caution. So we did one related to COVID. Is this the one that? No, this is somebody else did it. It's not John Eichel. Yeah, it is. So we did this one. It's accelerating clinical trials or anti-coronavirus trials. Anti-coronavirus trials, or the ACT trials that we did. And it was an open label, factorial, randomized controlled trial. And the issue here was looking at different treatments for it. We did not do it like the recovery one, which was a platform trial. And a platform trial, you can, if a drug doesn't work, you take it out and now you start another drug and do it on the same machinery of your trial. But we did not have that ability to do it in Canada. So we ended up doing a different type of design, but it was looking at rivaroxaban plus aspirin and in some groups, and we had colchicine versus control, and we had then rivaroxaban plus aspirin versus control. Those are the ones that we had. So it was a massive effort to try to do this, but again, it was possible to have this done. Not as rapidly as they did in the UK, but we were able to do it. One other example I'll give you of an incomplete factorial design is one that I also had the benefit to participate in with Professor Drossman. And this was treating functional bowel disease, which many of you may not be aware of, doesn't have a pathology for it, right? So people think it's depression, anxiety, or whatever. So they give an antidepressant to people, but a colleague, psychiatrist, suggested using cognitive behavioral therapy. So you could have done this versus educational therapy, which is a placebo therapy versus placebo, but they did not allow us to do both placebos. The ethics committee said no. These were mainly women. These people need to have something, so you better give them something. And so we ended up doing a incomplete factorial design for this. Oh, okay. 29. Yep. Oh, yeah. So what happened was that this was happening very fast during COVID, right? And so people got randomized, but then they didn't show up. And so this is a problem that we'll talk about intention to treat later on. And so theoretically, these people, you need to put them in the group that they were treated in. And they were not treated for the colchicine control, but they did participate in the rivaroxaban plus aspirin. We were able to get them back for this. And so we ended up having all of this, we called it modified intention to treat. And so this was a difficult thing to get published because of this. We'll talk more. Everybody, there was one person who said he wanted to learn more about intention to treat. And intention to treat, just to very quickly, we'll get to it later, but intention to treat means that as artificial as your trial is, right? Because you're doing an experiment in a very artificial situation where people are expected to follow a protocol. You are going to monitor that they're following the protocol. If you show it works, in real life, people will do whatever. And so in real life, what happens? Let's say you patient that comes to you and they have a condition, you do the diagnosis, and you say, my prescription is you to do this. Either to take this drug, take this injection, do this thing, lose weight, stop smoking, blah, 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 blah. You give them a prescription. And what does the person do? Whatever they want. It's out of your control. You intended to treat them with your prescription. That concept is exactly what intention to treat is in a trial. When you randomize them to A or you randomize them to B, you have intended to treatment with the protocol for A or the intended to treat them with the protocol for B. What they do, you may try to control it, but I can tell you it's very hard to control. No, so no, but they have to bring the pill count. Yeah, pill count. They just throw it away. Or they have to do this. They have to put these drops in their eyes. And we have this little fancy thing on the cap of the eyedropper thing that every time you tilt it, it registers one. So they know they're not stupid. They get carpal tunnel syndrome from doing it, but they'll do it so that they've taken it. So they do that. People do whatever they want to do. And so real life is intention to treat. If you intended to assign them to that, and come what may, but we had in that trial of taking cholestyramine sawdust and taking placebo sawdust 6 times a day for 7 years. Do you think people adhere to this thing? So they expected people would not. So they had 2 months of trial before somebody was randomized, because once you randomize, you have to analyze them, where you assign them. But before you randomize them, you check, is this person somebody who is going to comply? So you give them, everybody, you give them that placebo one, and some of them, they did it at random. Some of those, they had for 2 weeks, no, 2 months, 2 months of this stuff, because they have to go for 6 years, right? 7 years. They gave them 2 months of that, and in some of those days, they had the active thing, because you wanted to see if they were allergic to it or they had some adverse effect. So you check that. But main thing they were checking is, are people willing to drink sawdust for 7 years, right? 6 times a day. So they put a little marker in it. You could check their urine sample if they were taking it or not. And the people that did not comply, thank you, goodbye, we don't randomize. Because if you don't comply in 2 months, you're never going to comply in 6 years. Now, some people complied, and after a month, stopped taking it. After 2, 4, 8 months, stopped taking it. More people stopped taking it in the placebo. More people, a lot of people stopped taking it in the intervention arm. Some people, instead of taking 6 times a day, took 2 times a day. Some people took 1. Oh, I forgot, I went on holiday, I didn't take it, I came back, and I only took it this. I did. Doesn't matter. That's real life. We analyzed all 3,810 had to be analyzed. And that's the issue, right? Because that's what real life is. So for the colchicine versus control, these people have been randomized. So they had to be included in the analysis for the colchicine as to whatever group they were in, whatever their effect is. But they did get randomized to rivaroxaban plus aspirin or control. But again, here, some of these controls did not take that. And here also did not get it. So we had that problem. And trying to explain that to the reviewers was also very complicated. And took a while. Okay? Any other comments? Yes. What does interaction mean? So it means that the effect of one of the interventions, so one of the factors, because you have intervention factor A, yes, active intervention A or control intervention A, and then you have factor B, so active B or not active B, right? So those are 2 factors. And you could say that the effect of one of them depends on whether you get what you're getting on the other one. So the effect of A depends on whether you get B is going to be different than the effect of A if you don't get B, or the same thing. If you get B, the effect of B will depend on whether you get an A, and it may be different if you're not getting A. So for example, we could say that I give you a routine to get you to be healthier, and I'm going to measure your body mass index as my outcome of measure. And I'm going to give you an exercise routine. And I'm going to give you the exercise routine active versus a exercise routine that is passive. And then I'm going to try to see a diet. I'm going to give you a very low in carb diet versus a not low in carb diet, but that they have the similar kilocalories. I want to control the kilocalories. So I'm not going to change the calories, but I'm going to give you low carb, maybe low carb, high protein, high fat, while the other one is a mixture of all of those. Now, the question is the low diet effect, a low carb diet effect, different if you exercise than if you don't exercise? If you exercise a lot versus exercise a little. Many people will say yes, that if you get the effect of a diet depends on whether you exercise or you don't exercise. So that's an interaction. Is that clear? Okay. Oh, for the crossover, the washout period will depend on what your intervention is. So if it's a drug, a pill, you go to your pharmacoepidemiologist and they will look at pharmacodynamics and pharmacokinetics, and they will tell you the effect of this drug will be gone after 3 days, or it'll be gone after 40 weeks, or whatever they tell you. That's if your intervention is not some pill or some drug or something like that, it may be longer, and it may actually never go away. So you can't really do it because if I've done an exercise routine, you've learned the exercise routine. I can't get you to unlearn the exercise routine. The 4-arm parallel of a 2x2 factorial is the same analysis. But you can do a 4-arm that is not a 2x2 factorial, right? You can take drug A, drug B, drug C, drug D. Now I have 4-arm parallel. It's not a factorial. Factorial is when I have 2 factors that I'm doing at the same time. What I'm saying is that the analysis, or conceptually, it's the same as a 2x2 factorial is the same as a 4-arm parallel. So that means that if there is an interaction, then you're not getting the benefit of 2 for the price of 1, right? Because if I have no interaction, then I can see the effect of A by studying this, 200 people and 200 people. And I can also answer a separate research question, what is the effect of B, by studying these 200 and these 200. So by the same study of 400, there's one study, I'm answering 2 questions, the question of A and the question of B. But if I have an interaction, I have to answer the question of A would be, if there is no B, here's one question of A, and here's the other question of A. So I have now one study here and another study here. So that's 2 studies with these in this one here. And then to answer this one, I have to, the effect of B, I have to say when you don't have A, which is this one, and when you do have A, what is the effect of B, is this one. So I have, to get the 2 studies, I have to do this 2 separate studies. Right? So I don't get that benefit. Does that make sense? Yeah. Yep. Yeah. So what epidemiologists call effect modification is what statisticians call interaction. It's exactly the same. Yeah.
They are used for analysis. You take all the persons who are randomized. But how would you know the effect size if they're lost to follow? When you have no ways of monitoring them, how do you include them for analysis in the end?
Yeah. So that's a good question. It's problematic. So what many people do is that your outcome variable, we'll talk about the outcome variable later, is usually not a measurement or an observation. If I have to measure your fitness at the end, if I have to measure your BMI, if I have to measure your intraocular pressure, if I have to measure something, or I have to observe if you are dead or alive, if you are in remission or not in remission, I have to observe that, and you're not there, then you're missing. So if I have missing data, now I have several alternatives. I have the alternative of making it up, which will be criticized, of ignoring it and doing only complete data analysis, which will be criticized because it's potentially biased, or I have the alternative of committing suicide. Right? No, just joking aside. So it is problematic. Missing data is very problematic. So what people do is they will make up the data. First of all, hope that you don't have more than 1 or 2%, so that when you make it up or you do it, you do sensitivity analysis, you do multiple things, and you hope that your main message, your main result doesn't change under all of these things. If you have, 3%, 5%, 10%, it will affect your results. But if you have less than 1% or 1.5%, maybe 2%, maybe if you have a strong effect, that 1 or 2% is not going to affect. So that's what you pray to whichever God you like to pray. That's what you pray. That's maybe the best alternative to pray. But people make up the data, do sensitivity analysis, and they use fancy terms like imputation. Imputation is really making up your data. So when I meet with a physician and they say, well, let's do multiple imputation. Oh, I thought you want to invent your data multiple ways, multiple times. They don't like the term, but you're making up data. The best way to deal with missing data is to not have it, right? That actually sounds like a joke, but it's true. You do every effort to make it not possible. So studies that are done, trials that are done in hospital are easy. The patient doesn't go anywhere. Studies that are done in public health, people go away. You need to also make sure that they do come for follow-up. You pay for the parking, you pay for the transportation, you give them lunch, you make it easy for them to not get lost. In that study of cholestyramine, there was 3,810. The government had invested $120 million. They did not want to have a single loss to follow. And back in those days, 1970s, it was still legal to do this. These are men 35 to 59 in the United States and Canada. What do men 35 to 50, some of the men will do? They will have a love affair. They will divorce their wives. They don't want to pay their kids. They disappear. How do we find them? We needed to find out if they had a heart attack or not. So what they did is they hired detective agencies to go and find them. And they found them. They didn't care whether they were paying their wife or not. Did you have a heart attack? No? Fine. Did you have a heart attack? Yes? Okay, fine. That's it. There was one of them, a very interesting side story. He was at the clinic in Texas, worked for an oil company. His oil company sent him to Saudi Arabia. And in Saudi Arabia, the Americans that go live in an American compound where they live like the United States. And he went out to visit some friend. He had a bottle of alcohol in the trunk of his car. Police stopped him for something. They found the alcohol. He was put in jail. His wife in Texas said, "Oh, my husband is in jail in Saudi Arabia." So they hired a Saudi Arabian doctor to go to the jail, find out if the guy had a heart attack or not. Not to get him out of jail, that's his problem, but to see that. But they got, that's the only study I know, 3,810, and they got all 3,800. Now, the other thing we'll talk about on Wednesday is the analysis. And so another way people do this is they don't study as outcome the occurrence of something, because I have to observe it, or the measurement of something, but we study time to some event, time to get in a heart attack, time to a stroke, time to get in cancer remission. So when somebody gets lost, you know when they got lost, so you censor their information at the time when they got lost. So everybody has an outcome. So that's a little trick that people do. They choose their outcome so that they don't have to worry about missing it.
In present generation, present days, while you're explaining inclusion into trial, do people consent for this amount of rigorous follow-ups? Don't
yeah.
they?
Yeah, so you ask them, you know, are you willing for us to give me your PI personal ID number, tell me where you work, give me your mobile, give me your wife's mobile or husband's mobile, give me your children's mobile, give me where you work here, where you do this, where you do that, where you go to temple, where you do this, who are your neighbors. Give me all of this. Nowadays, you can track a lot of people easily. Yeah, they don't put a chip in them, but you can track us. Yeah.
In a factorial study design, how do you account for a third factor which could have influenced the outcome? Like, for example, in your hypertension study in NEJM, supposing they had weight loss also simultaneously, you give two
So
drugs.
randomization will do it, right? If you randomize enough people, all these other confounders will be in the factorial design will be accounted for.
It's a prospective
Yep.
design, right? So if that could, supposing it had still happened,
Oh, so no,
prospectively.
so you're saying if people lose weight during follow-up or change weight or whatever, yes, that is something that is going to happen in real life. Most people ignore it. And so what intention to treat says, doesn't matter what happens. Once you randomize, you analyze them, people will change, their factors will change, the behavior will change. They've been randomized to diet, and but they may change their diet. You said, oh, you're to diet and low exercise, but they may decide to do more exercise. They may lose weight. They may do that. But you let it happen. And the idea is intention to treat, right? So now there's two things that we do. The basic analysis, the primary analysis, is always under intention to treat. That doesn't mean that you cannot do secondary exploratory analysis. So you judge your trial, your effectiveness of your intervention, under the intention to treat principle, because that's what people say you need to do. And you publish that p-value and you say this works or this doesn't work, and that's it. But you're not prohibited from exploring. And you can always explore. And you can say, well, we looked at, and a possible explanation of why we got the result we got is because this happened, or this happened, or that happened, or whatever. You can do that. Those are called secondary exploratory analysis. What happens though, or used to happen more, is that people would get a non-statistically significant result for the intention to treat. And they would now, some people have done this, will say that their secondary analysis was their primary analysis because they got significance in the primary analysis once they adjusted for this or that. This is why today we all have to register our protocols and our statistical analysis plan before we do our study, because people, other investigators have cheated in the past. And because there are cheaters, all of us have to do this. Because we don't know who is cheating and who's not. So that's why the WHO has the registration of the trials, or the US clinicaltrials.gov. As long as you register someplace, you're okay. Otherwise, no journal will take your paper because they don't know. Yes. I don't know if we're going to be able to continue with the lecture. Right.
Do we account to that during the time of sample size calculation?
Yes.
And take it like.
Yeah. So because the loss to follow-up will entail some loss of statistical power. So you inflate your numbers, so account for that. But you still hope that you don't get as many because you will have to do sensitivity analysis anyway.
The clinical scenarios in which you have told about the incomplete crossover design is the patient wishes to say yes to A or no to B, then the other one.
The patient doesn't wish anything.
So
You
you're
assign
that's-
them randomly.
Is it?
Yeah, the patient doesn't decide what they get.
So the A, yes, B, no means?
Means that you've assigned them. You when we talk about randomization, you take 4N people, 400 people, and you flip your coin, and they go to no, or they go to no, yes, or yes, no, or yes, yes. So you have a four-sided coin or four-sided pyramid, right? And you toss that, and whatever that patient gets, that's where they go. Patient never decides. This is why clinical trials work, because you as investigator, you assign the intervention. There is no self-selection bias as to what I want to get. They never decide. What they do decide is whether they want to participate or not. So that's the consent process. At the time of you say, we're doing the study here, you have this condition, you have met the criteria to be eligible for the study, would you like to participate? And you tell them, if you participate, these are the risks and benefits to you. If you decide to participate, these are the risks and benefits to society for you participating. If you don't want to participate, these are the risks and benefits to you. And if you don't want to participate, these are the risks and benefits to society for you not wanting to participate. You inform them of all of these risks and benefits. Then you say, are you willing to get any one of these four? If they say, no, I don't want, I only want this, then okay, thank you, goodbye. We'll treat you for that. But we don't know if it's any better or not, but we'll treat you. You are not part of my study. They have to say, I'm willing to follow any one of these four. And only then they sign the consent. And once they sign the consent, then you toss your little pyramid. You don't do it before. They never choose.
Yeah. In any one of these two, and also possibly both also.
Yeah, exactly. Any one of these four things, four groups. All right, maybe we should continue. Otherwise, we will never finish the lecture. But these are good questions. Where were we? Oh, this I just wanted to mention. The one time where I've seen a combo study, a combo crossover and factorial, was in a hypertension medication. And so they had felodipine and candesartan. And so the factorial part was you either get both or one or none. But they also wanted to do it in a crossover. So they had those four, but they had A, B, C, D. So they had a crossover part. So people that got A then get B again, like that. But they had it in such a way that A follows B. Oh, sorry, B follows A the same number of times that A follows B. And B follows C the same number of times that C comes before D. And B follows C, and C comes before B. All these clever ones so that there is this. This is called a Latin square design. And this was done in agriculture back in 1920s. And people do this. But it's very hard to do, hard to see. I haven't seen others. Now, here's the other design that is common. So far, we've been talking about individual patients, individual people being randomly assigned. But that's not always possible. Suppose I'm doing a study in children, and children that are not patients in a hospital, children that are walking around, going to school, playing. They may be at risk for something, maybe because they are children that don't eat well, or maybe they're children that don't exercise, or maybe they're children that don't are obese, or maybe children that have this or have that, but they're not considered patients. They don't go to a clinic. They're not part of any treatment ongoing. Where do I get them? If I wanted to study these sorts of children, I could go, they don't come to my clinic, so I have to go to their homes. Then I have to go to multiple homes, find them. It's a whole lot of effort. But luckily, by law, children have to be in school. Well, why don't I go to schools? And I get children in schools to participate in my study. Now what happens? Well, if I go to, we did a study in children that were in 3rd and 4th grade in primary school. And you have to get permission of the principal, the school superintendent, and then the teacher of the class. And the teacher will say, you can't just take individuals. One child gets this and another child gets that. Or all of them get the same thing, or get out. So you have to randomize the classroom. Well, but then they're lunchtime or whatever, they're playing outside and they're talking to each other. The interventions get contaminated. So now the whole school gets something. So now one school gets this, another school gets that, another school gets this, another one gets that. So now I'm not randomizing kids, I'm randomizing schools. And that's a cluster. And so we are sometimes forced to do clusters. We had another one where in southern United States, there's a lot of poor people that work in factories doing routine work, and they are usually sitting down, sorting things, or they're sitting down, the dead chickens are coming by and they're taking off the feathers, or they're processing or whatever, and they're sitting. There's a lot of poor people do this. They have poor diets. They don't eat well because they don't get paid well. They have 15-minute break and they go and smoke and then come back and do the same thing over and over. And so one investigator, public health investigator, she wanted to say, what if we do some little aerobic exercise or something that is fun for them to do during the 15-minute break, so they get some benefit? Well, you can't randomly assign one woman to get it or not. You have to get the entire factory, right? So then we get these cluster things. So it's used only when individual randomization is not practical or feasible. We could not do it. And so we now randomize one factory or one clinic. Sometimes I do it in clinics. We did another one, yeah, it was a pediatrician counseling parents on different ways for getting their child to do something. I think it was the behavior, so like preventing bullying and this and that. So he was advising some kids to do something and other kids to do something else. Well, as fantastic a pediatrician this person would be, they would mix the messages. If they had to counsel this family one way and this family another way. And so we argued, no, you may be God's gift to earth as a pediatrician, but you are another human and you will contaminate your intervention. So we will randomize, you will only give message A and your colleague will give message B. So that they don't mix it up. Okay. So now we're randomizing, oh, but they work in the same clinic. Okay. The entire clinic gets A and the entire clinic, another clinic gets B. And so they don't have contamination. Now, so if a clinic or a school or whatever gets A, another one gets A, everybody here gets A, everybody here gets B, and so forth. If there's a clinic effect that this clinic treats well-to-do people, this clinic is a public one, even though they follow the same protocol, their clientele is different, their education is different, things happen, or the schools are different, or the teachers in the schools are different. One is a public school, one is a private school, one is a religious school, one is not, one is big, one is small. There is a school effect. There's a clinic effect. And so we have to take into account two problems statistically, is that the clinic effect is related to how much correlation there is among the people of a given clinic in the outcome and measure. So we did this study also it was an educational thing to get the math scores to go up. Well, if the teacher is good, then all of the math scores of the students in his class are going to be similar and good. Or if the teacher is bad, then all of the students in their class are going to be bad, but similar. That similarity is the correlation among the scores within a kid, within a teacher. So we have to multiply the variability, increase the variance by what's called the design effect, which is take how much correlation there is among those math scores or among the obesity indices or whatever is your outcome of members of a particular cluster, multiply it by the average number of people in the cluster, minus 1, and add it to 1. Now, if you take more than, this is only 0 if there's only 1 person per cluster, so it's not a cluster. So this is always positive. This is a proportion of correlation. It's an index of correlation. It's not a true correlation, so it's never negative. So this is positive, this is positive. So this added to 1 is greater than 1. So you're multiplying the variance by something greater than 1. You're making it bigger. Now you remember what I said at the beginning. If I make the variability bigger, I'm increasing the noise. So whatever signal I have is going to be harder to detect. So these cluster trials have very hard to find effects because of large variability, because I have to inflate the variance. The other thing is, I may also have smaller effects because I'm not intervening in the entire school individually on each child, and a child may not pay attention in class, they may fall asleep, they may do this, they may not come, they may do that. And so if I'm now analyzing these children, I did not reach each child, or each child did not listen. So the effect of my intervention, I did not control very well the implementation. I cannot. I also depend on the teacher doing it. Teacher's not going to let me go in and do this every time. So I have to train the teacher to give the lesson the way I want it to be done. And the teacher may not do it well. So now the effect is smaller, the noise is bigger, it's very hard to get results. So we only do this when we have to. Ideally, we would be able to randomly assign individuals, not groups of individuals. We've had to do this in a situation where it's impractical or not feasible to do individual randomization. We don't do this by choice. Right? Here's a study that was done in rural India to improve control of hypertension. And they did it in a cluster design. And they had a group-based intervention by Anganwadi workers, community health workers in 5 villages. And they had usual care in 10 villages. They standardized usual care. And notice here, they didn't have equal number of villages. Why? Always think about this when you see it. Then it's probably more costly to get more trained people to do this group-based intervention. And it's also, the more controls you have, the better. You have more sample size. But they decided we can only afford to do this and time and effort, et cetera, in 5. They could not do 10 and 10, for example. And so the outcome was blood pressure control 2 months after completion of intervention and in 3 rural regions of South India. And, you know, people talk about a clinical trial in terms of the PICOT. They started off by saying it PICO, but then they added the T and I've added the S for the setting. So they had 1734 people with hypertension and they did it in villages. Why did they do it? Because it was an educational and monitoring program. I cannot educate one person in a little village and another one with a different education program and hope they don't talk to each other. Right? And that's the issue, because it could not be done any other way. So people do this, first of all. This is a study that was done in Argentina and Uruguay in South America, where they wanted to improve the practice in delivery of active management of the 3rd stage of labor. They got that right. And because they were using episiotomies indiscriminately, mainly because they were not needed, but they were just doing it. In fact, they were doing C-sections because it was something that was the preference of the physician. So he or she could go play golf. And so we don't have to worry about when this lady is going to deliver. Let's just do this quickly and get out of here. But they also were doing the episiotomies indiscriminately. And so they wanted to train people in the obstetric group in active management of the 3rd stage of labor with oxytocin or whatever. And so they could not, at the moment of the woman giving birth, randomize a woman to be actively managed or not actively managed, because the obstetric team was trained in this. And so now they have to say, wait a second, I have to be untrained and I have to not manage this person? No. So the whole clinic had to do it, right? So they had 24 clinics in Argentina and Uruguay. And so, and they did this, right? Because if the trained clinical staff could not practically change their behavior for different women. So it's a common thing, again, when you need to do it. Now, there's a great paper here by David Murray on characteristics that distinguish the cluster randomized trial from the more familiar individual randomized control trial. So the unit of assignment here is an identifiable group, not a group that you make up. It's a group that exists, either a clinic, the school, the factory, the village, the community, a church group, something where people themselves have made it into a cluster. It's not formed at random and not formed at all by you as investigator. Oh, I'm going to take the men and the women. That's not the way it works. Okay? Different groups are assigned to it, and you're creating a nested or hierarchical structure for the design, meaning that the data of all the children in the same school are nested within that school, or all the kids that are advised by this physician are nested within that physician, or all the women that work in a factory work in that same factory. They don't work in multiple factories, then it doesn't work, for example. The units of observation now are members of that group, nested within the condition and the group. And so this is the problem. We're randomizing those groups. And remember what I said about randomization. Randomization is going to work when I randomize a lot of things. If I randomize 20,000 people, I can guarantee you that everything is nicely balanced before you start the intervention. Every confounder that you know, every confounder that you don't know is balanced. If you randomize 10,000 people, most likely it'll work. If you randomize 5,000, maybe it'll work. If you randomize 500, not very likely it will work for everything. If you randomize 100, possibly nothing. Maybe you're lucky and you get some things done. But now we're randomizing few schools, few factories, few villages. Almost nothing is going to be balanced. You may try to standardize, oh, all my villages are between, I don't know, 500 and 1,000 people. They are in rural Tamil Nadu. They are, not close enough to any major metropolis. They have such and such, agriculture is their way of living. They have this thing, they have that thing. They're all very, very similar. But I guarantee you, there's things that are not going to be similar. And they may be small, you may not even know about them, but they may impact the result of your study. And so we don't get that benefit. But we have to do it because there's no other way of randomizing. And so because we have a limited number of groups that are assigned, we have that imbalance. So we know why we do it. There's some examples of one. This is a program by WHO on safe communities, and they were looking at group level effects. This is that study that I mentioned on 3rd and 4th graders and elementary school children that was trying to get them to eat better and do more exercise, when we know that 3rd and 4th graders, what they eat depends on their parents. And so that was very crucial doing this kind of study. And they were interested in school level effects as well as in kid level effects. And there was another very interesting one that we participated in. And this was a professor in the Department of Health Behavior and Health Education, again, in rural South United States, where there's a lot of women, Black women, that are poor, that have unhealthy eating habits, that smoke, that eat a lot of fatty foods, because they're poor, don't have regular checkups, and they have colon cancer that is detected too late. And so she wanted to say, can we get women to improve their behavior in multiple ways? One is to stop smoking was one, but one that she was able to claim was going to get an effect was to have them eat more fruits and vegetables. And so the problem is these women are not going to a clinic. They're not patients. They're living in the community. Where do they go? She found out, oh, they go to the beauty salon. They go to the beauty salon very regularly. They go to the same beauty salon. When they go there, they don't go like most men do to just have their haircut in 10 minutes and out. They go there for lots of stuff. And they go there to spend an afternoon. They go with their stylist. They talk about life. They talk about this. They talk about that. Not about who won the last cricket match and out. They talk about everything. And what happens is that the stylist becomes their friend. The stylist starts giving them advice. Oh, you should do this. You should do that. The stylist gives wrong advice most of the time because she is not trained as a public health worker in giving proper advice. So this lady decides, what if we train them and do an intervention where we train the stylist to give the proper advice? And we randomize stylists. Can we randomize the individual patient? No, because once the stylist is trained to say advice this way, she cannot randomize individual clients. So the stylist has to do it. And if there are multiple stylists in that one place, all right, so all stylists at one beauty salon get it, and other beauty salons don't get it. And so in this study, it was a 4-year randomized controlled trial. Look at targeted health magazines. They put their stylist training, and they wanted these to have 3 different outcomes: eating at least 5 fruits and vegetables, reduce calories and fat, increase activity. And they had 40 beauty salons that were randomized, and the units of analysis was the 1,100 clients. And they were able to show that women did increase and statistically significant a half a portion of fruit and vegetables, which is a big thing in women that are poor, when fruits and vegetables in the United States are the most expensive item. Junk food is the cheapest thing, but good stuff is expensive. All right, so if you do cluster designs, what's the implication? You have fewer units are being randomized, so you don't get the benefit of randomization. You have to get consent from not only the person who's going to be in the study, but from the school, from the factory, from the beauty salon owner, from the village elders, for example. And you don't get individual consent then necessarily. So in the schools, because we were talking to children, we had to get consent of the school superintendent for the whole district, consent of the principal of that school, consent of the teachers of that third and fourth standard, and and consent of the parents of each child, and then verbal assent from each child. And this child was interesting also as an anecdote, because they were taking cholesterol measurements, was a finger prick. And these third and fourth grade boys were cowards. The girls were fine. But the boys were, oh, no, I don't want this. And luckily, this by the School of Nursing, so the research assistants were all young girls, nurse students. And they said, oh, come on, you boys, look, we can do each other, it doesn't hurt. And then the boys became brave because, oh, the girls are doing it, then we can do it. I think they're, what is it, 9, 10-year-old boys were cowards. Now, once cluster is randomized, you need to tell them what cluster they're assigned. So let's say you're doing this clinic in Argentina, where they're going to be randomized to active management of third stage of labor versus usual care. You have to tell the woman, oh, you know, by the way, our clinic is participating in this study, and we've been randomized already to do active management. So we're going to do this. He said, no, I don't want that. But what do you do? So they had to go to another clinic. So I've been treated all my life. I had my 2 previous kids born here, and now you tell me you're going to do this, blah, blah, blah. And there could be problems. So you have to be careful, because you may have participants may leave and self-select themselves to participate or not. Those factories where the women had to do exercise afterwards, they didn't want to participate. Not all women wanted to participate. Leave me alone. I'm just going to smoke. And they would smoke. What do you do? You still have to analyze these people. And that's the problem, because you're not going to get a strong effect, because people know what they've been assigned to. And they are like any other human being. They'll do whatever they want. And so you cannot even mask people, because people know what they're getting in most cases. And so, yeah, we also had adherence issues at both places. What happened with the beauty salons, I did the calculation for sample size, and they needed 36. And I told them, you better get 40. No, 4 more is going to be more expensive. You better get 40, because if you may lose some beauty salons. And what happened was exactly, they lost 3. What happened was, in one of them, or 2 of them, the beauty salon owner sold it to somebody else. The new person came and said, what is all of this stuff here? All these things, posters of being in a study. No, I'm not going to, new clients, get out. No, get out, can't do anything. They removed consent. And another one was actually one of the original owners remained there. And he said, you know, I've been studying. I know, he said, I always get 5 to 10 new clients every month. Since you put here all this stuff, I'm not getting any new clients. Get out. Remove consent. So this happens. So you may experience, if you lose a cluster, you lose all the participants from that cluster. So you try not to lose a cluster. You may lose a participant, or 1 or 2, which is not bad, but you lose a bunch, you're in trouble. And then you have to increase the sample size because of the design effect business that I mentioned already. So there are papers that deal with how to increase your sample size to have efficient cluster randomized design. Some people do cluster crossover designs. And that's an interesting thing because you've lost power. You can either recruit more, which is more expensive, or you can do a cluster crossover. And a cluster crossover is you do a crossover of the cluster. So this is actually, we did this in Hamilton in Canada with one of the cardiovascular intensivists, is how she calls herself. She's an MD, and she works with, heart patients. A lot of people, they put a lot of stents in people. And there was a traditional length of the stent, I don't know, 2 centimeters. And then there was another one that was maybe, one was 1 centimeter or 3/4 centimeter. There were 2 different sizes. She said, I think that the smaller stent is better than the bigger stent. Okay, whatever. You are the cardiologist here. Then I want to do this in a trial. Now, the problem is, how do I randomize? I can't randomize having the small stents and the big stents in the operating theater at the same time, because the physician operating says, stent. Somebody's going to grab it and, oh no, I have to randomize and see. No, you can't do that. You've got to grab what's there. And I can't have one patient randomized to this and another patient to that because they will forget and they'll grab whatever they can quickly and do something. So he said, we need to randomize it during a month. So month A, we put the box of the long stents, and then month B, we put the box of the short stents there. We cross over. And that way, now some hospitals get short and long, and some others get long and short. And now we have double the sample size, yeah, because the effect of the stent goes. There's no washout period. The only washout period was the night when somebody goes and removes that box and puts the other box in. That's all. So it was possible. And we also, and what you do multiple times, you can cross over not just once, you can cross over 2, 3, 4. We can get more power by doing that. So then we can do cluster crossover designs to increase the power. And there is other designs. One is called wedge that Professor Tambo mentioned. This is another one that we do. And stepped wedge is a cluster randomized one that's useful for increasing power, but also it is applicable in situations where washout is not possible. It's being used in many fields, like when the intervention is an environmental intervention. So I was just in Delhi at a course on road safety, and what the engineers wanted to show is that can we do trials to show that lowering speeds in arterial roads in cities is of benefit in reducing the number of crashes or the severity of the crashes that occur. Okay? And there are multiple ways of reducing the speed. They do it by putting rumble strips, which you may not be able to do in arterial roads. You may be doing it by psychologically, if you take the lanes that are 3.2 meters wide, make them 3.1 meters, you paint them as 3.1 meters or 3 meters wide. Psychologically, people think that they're going, if they keep to the lanes, which they don't do in Delhi. But if you keep to the lanes, you say, oh, there's traffic, I'll slow down. Or they put trees, and they put barriers, or they make a little thing. There are multiple ways. But do we know if it works? Well, once I do that change, first of all, it has to be, what am I randomizing? I can't randomize people. You're going to drive here, you're going to drive there. No. I randomize road sectors. That's the cluster, the road sector. And now I'm going to analyze the drivers that go there or the crashes that happen there or the pedestrians that get killed there or whatever. But I'm going units within road sectors, okay? But wait a second, once I've done, I have very little power because I'm going to take a few road sectors. I can't do a crossover. I can't remove the barriers now and let it go back again. And if I talk to the mayor of the town or the city, they'll say, oh yeah, let's do this. No, we have to be willing to be randomized to get it or not get it. No, we want it. If you're going to reduce the speeds, we want to. But you put your money, you do it. We don't want to not get anything. We don't participate in your study. No. Everybody will get it. But some of you will get it before others, and others will get it later. So we use that when everybody thinks they want it. So it's a desirable intervention, especially when it is a one where we cannot remove it and it's possible. And so this is a busy slide, so I'll show you some of these designs. So I'll come over here. Suppose I have 8 clusters, okay? And I want to do a randomized to intervention or not intervention, usual care. Usually I'll have a time period where everybody has not been randomized yet. And now I randomize 4 of them, end up getting the intervention, and I can follow them for a long time, or I can follow them only one period. The more I follow them, and I get different people at different periods, I get more data points, so that's good. And these will stay in control. But this is a parallel design. Some 4 of them are getting this, and 4 of them are getting that. But people may want it, and this may not be possible. And I lose power because I have only 4 in one and 4 in the other. So I can do a crossover. So these 4 get this intervention for some periods, and then they cross over to control and go back. That's one way. Or I can do, if I cannot remove the intervention, I just don't do control here. I can do an incomplete crossover. So these people crossed over like that. Or I can do multiple crossovers if it's possible to remove it. So this goes and keeps alternating like the stents kept alternating. But this is the stepped wedge. And that means that at the second time period, one of the 8 gets randomized to intervention. They get it first. And they get the speed lowering environmental change. These 7 don't. Then another period goes by, I don't know, 3 months, 6 months, whatever. And now you randomize out of these 7, one of them gets it, this one doesn't. And so forth to keep, after every 6 months, you randomize. Eventually everybody gets it. Everybody's happy because everybody got what they wanted. You're happy. Why? Because now you have, here have 8 times 972. So 36 control periods and 36 intervention periods. I have lots of data. Problem is, I have to now look at other correlations. I had the correlation within a cluster, but now I have within a cluster over time. So these, the first cluster, are correlated because they come from this cluster. And then within each one, I have within cluster correlation. So I have the intra-cluster correlation, and I have the inter-period correlation, where all of these have an inter-period correlation. So power is reduced a little bit, but you've recuperated it quite a bit this way. And this study is being done in many situations. First of all, because I'm in the need to do a cluster design, because that's the only feasible way to do that trial, to test that intervention. It's a policy. I could test a law. I could test enforcement of a law. I could test an educational behavioral intervention that everybody is going to eventually get. I can test something that's desirable. I can test something that's an environmental intervention that I cannot remove. And everybody's happy. And investigators have. The problem is that, you have to do it a long period of time, because if to notice the effect of the intervention, whenever you do multiple periods, it cannot be done to look at something that is a chronic problem. In traffic crashes, it's a problem because crashes don't occur all the time. Some places like Delhi, they do occur all the time, and that you can study it there. But places where there's not, you have to wait for crashes, have enough crashes to be able to study this. So some things for rare events, it's not that common. For things that are not rare, it's possible to do. And so people are doing these sorts of studies as well. Okay. So this is intra-period correlation, inter-period correlation. So if we end up doing these cluster designs, we need to adjust some things. At the design stage, we're not going to get the benefit of randomization, balancing the groups. So we need to put restrictions on randomization. So we call it restricted randomization. And there's different ways of restricting randomization. And what you're doing is basically trying to balance things on known confounders. We're doomed here on unknown confounders, just because we don't have enough units to that. But on known confounders, we can stratify, we can match. There's this thing called minimization and optimized randomization. We'll talk about that after lunch. At the conduct stage, we have to get this consent at cluster level, at participant level I mentioned, and you're delivering interventions to a group, but you don't know who's actually getting it individually. And at the analysis stage, because we have few analysis or few units, we have a choice. We can analyze at the cluster level. So I get one value per road sector, one value per clinic, one value per factory, one value per school. And I can analyze those few, like 15 villages I had in that study. Well, I only have 15. So I cannot do modeling statistically. I cannot do anything but a robust non-parametric permutation test, for example. So we end up with much reduced power. If I do it at the participant level, instead of having the 37 beauty salons, I have 1,100 women. I have more observations, but they're correlated. And then I have to adjust for the correlation. So standard approaches no longer apply. And I have to call a statistician. That's why we're here to help when these things happen. And we will talk on Wednesday about interim analysis. And interim analysis is I would consider it the interesting part of the analysis of clinical trials. And that is, remember, we started a trial when there was equipoise, and you could do a trial. But once equipoise is gone during the trial, that means that you've already have enough evidence that one is better than the other, then it's unethical to continue. And so therefore, ethics dictate that we do interim analysis in most trials. And so when you do this, you may, in these cluster designs, now you have to look at the benefits and adverse effects and harm, not only at the participant level, but at the cluster level. If we had, for example, out of those 40 beauty salons, we lost 3. We had lost about 12. Somebody would say, you can't do this because this study is not going to give a result that anybody is ever going to use ever. Because if you try to do this, no beauty salon is going to want this. So why are you studying this? That's because you had an adverse effect at the beauty salon level. We had other studies where people are recommended to lose weight. And this was one study that was done in 2 universities or community colleges. and it was losing weight. And one person, they were told not to do this, decided to run a marathon, had a heart attack, and died. He was told not to do it by the study, but the committee said, wait a second, your study is getting people to lose weight, and now people will lose weight, they'll die from running marathons. Is this going to work? So we had to argue, well, not me, but the physician had to argue. We put in the consent form that we should not do this, they should not over-exercise, blah, 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 check with the doctor. So it's not our fault. This person decided to do this. But luckily it was okay. Not for the person that died, but for the study. Now, we have other RCT designs, and this is a whole other topic. So far we've talked about designs where you have the traditional parallel design, factorial design, the crossover design, and those were individual randomized. And we had the cluster designs. And the way those studies are done, you design the study, you write a protocol, you say this is the study design, and that's it. It is almost etched in stone nowadays. You send it to clinicaltrials.gov or to the WHO registry, and you register. That means you have to do what you say you're going to do. No changes to it. But you all know that when you do something, any research, you may have to change things. And people are very much attracted to this term adaptive designs. And adaptive designs are often misunderstood. People think, oh, I can adapt my design. As things are not going well, oh, I don't like this outcome, I'll use this outcome. Oh, I don't like the way we're doing this intervention, let's do it this way. Or I don't like the way people are not behaving well with this, let's do this, let's do that, let's try to fix this, let's try to fix that. That's not adaptive. That's called ad hoc manipulation of your study. And that is not considered appropriate. Adaptive designs are studies that at the design stage, when you register it, you've already said how you're going to adapt it, when, and based on what. So they're not ad hoc, they are adaptive by design. It does not a way to deal with poorly done studies. It is a way to have thought about it and say, you know, we really don't know much about this characteristic that determines the sample size. We need to know the variability, or we need to know what is the variability maybe one. You don't want to do a pilot study. You want to calculate the variability before, but then keep the people. You're not going to change anything else. You just want to know, do I really need to have 500 people, or can I get away with 400 people? Do I need to have 2,000 people, or do I need 2,500 people? So you want to be able to say, okay, after I have so many things, I will calculate the variability and then maybe change it. If the variability is this much, I will add another 500. If the variability is this, I will not add anything. And if the variability is even lower, I may not recruit the full number. So now you have to say when you're going to check it and what you're going to do if you have this, this, or that. And that's what is adaptive. So many people misunderstand it and think, oh, I can adapt all sorts of stuff. Yes, you can, but not all. People call this all sorts of things. Flexible design, response-driven, dynamic, self-designing, multi-stage. Yes, they are multi-stage, at least two-stage, at least. But they're not ad hoc, okay? The crucial thing is that you're using the accumulating data to decide how to modify aspects of the study. But here's a crucial phrase: without undermining the validity and integrity of the trial. So, who is deciding this? The investigators are usually kept unaware of the effect of the intervention while the study is taking place. Why? Because you can manipulate all sorts of stuff in your favor. So again, and people have done this, that's why you're not allowed to know this. So who monitors the study? An external data and safety monitoring committee. We'll talk more about them. They are in charge of the not only the safety of the people, the integrity of the study by the data and other aspects of it. So study integrity is what they should be called. Data, Study Integrity Monitoring Committee. But they're called Data and Safety Monitoring Committee. Right? Some people call it Data Monitoring Committee. It's not just the data that they're monitoring. They are there to, because of ethics, to monitor the safety of the people. Why? Because the investigators typically are kept blinded as to what a person is getting. So if the person has a problem, who decides? If there's more adverse events in one group that are unexpected, it's not up to the investigator to decide it. It's up to these people to decide it. Why? Because if there is a problem, people are difficult at monitoring themselves. And you say, no, that's okay. It's not a problem. It may be a problem, but you don't want to be the problem, because if you stop the study, what do you have to do? If you stop a study early, you have to not follow people anymore, stop the intervention, inform people, and if you're halfway between, you have to return the money that has been given to you to do the study, because you're no longer doing it. Raise your hand if you, once somebody gives you money, you'd like to return money. Absolutely nobody likes to return money. So there's a conflict of interest in investigators knowing what's happening and in monitoring. So that's why we have external people that monitor stuff. And so if we tell them, oh, if I have a strong effect, then we're going to increase the sample size. If I have, or decrease the sample size. If I have a low effect, then I will do this. Well, then if the monitoring committee says, yes, at this stage we should increase it, then everybody knows, oh, we have a strong effect. That's unblinding. That study integrity is compromised. So we have to be very careful in these adaptive designs. So the general structure of adaptive designs is it's a multi-stage study, and at a given stage, the data are analyzed, and the next stage may be redesigned, taking into account the available data. So, for example, you may look at recruitment and say, oh, I'm not getting enough people because I have restricted too much people that have to have this or to have that. I don't want people to have too much high blood pressure or too much this or too little of that, etc. So now I may have adapt the eligibility to increase recruitment. Or I may say, one of the interventions, I want to be able to get more people into it if I have, again, a better effect going on. That may be tough to do. So I may want, instead of doing 1-to-1, I may want to do 2-to-1 or get more controls or do this. Sample size is what most people are attracted to do, increase or decrease the sample size, or enrich certain subgroups. Oh, I want to get more people from tribal communities, or I want to get more people from this group. I want to get more elderly people. I want to get this. Maybe because when you design your study, somebody else is studying that, and you may want to get more of those people. And then this is during recruitment stage where you have the option of changing your sample size, for example, or changing your eligibility while you're still getting people. Because once you've gotten everybody, you can't change them. So once you've recruitment is complete, at the conduct stage, some people still want to say, okay, maybe I want to add more people, or just I can get away with not the sample size, I should not say that, it's the follow-up time. I can end earlier because I don't have to follow them for 2 more years. I can stop now, for example. And this is what we do with interim analysis, and we'll talk more about this on Wednesday. But other people may want to change things. The crucial point here is that adaptive designs are adaptive by design. It's not something that you will do as you're doing your study and then all of a sudden decide, oh, I want to do an adaptation. Or things are not working well, let's change the protocol. Changing the protocol is different from adapting designs. The change in protocol is a change in protocol. It's not an adaptation. It's because you think something is not going well and you want to change it. And I can guarantee you, anytime you change a protocol, you are opening yourself to being criticized. Because say, wait a second, why did you change the protocol? Because we're not doing the study well, then that's negative against you. Or, oh, you didn't plan your study well. Weren't you smart enough to plan this good? So this is what people will say. Whether it's true or not is another thing. But think about it, when you are designing your study, you have to think about all possibilities. That's why almost never is there a study that is designed by one person. It's always a team of people. And it's a team of clinicians, a team of statisticians, a team of epidemiologists, a team of public health people, a team of, all sorts of research support people. But everybody has different points of view on this. So one thing we typically do, and many people don't think about it as an adaptation, is that interim analysis is an adaptation. It's an adaptation of when you end the study. So we'll talk about that more on Wednesday. Adaptive allocation is when you get an imbalance in the number. So you're just changing that. Or some people say, well, I'm getting the randomization because I have such few units. I'm not getting a nice balance between these arms on this. So I need to recruit more women, or I have to recruit more young people. I have to do this and so forth. Response adaptive is a tricky one because now this is based on the outcome of the result of this trial. And we talked about increase in sample size. Usually we base it on the overall event rate, not on the difference in event rate between the two arms. Because if you base it on the difference, then that informs the investigator of what's happening. So if you do it on the overall combined event rate, it's okay. Because then they're not get unblinded. And then you can do a follow-up duration to increase the number of events. This is fairly commonly done. It says our event rate is low. Can we follow people for another 2 more years so that more people die or more people get the event or whatever? And so these are some of the other ones that I've mentioned already that we do. So this is a good journal issue. In 2006, there was a pharma working group in the United States that, because pharma was very much interested in adaptive designs, and they convened a group to discuss how to do adaptive designs. And they came out with a whole issue in the Journal of Biopharmaceutical Statistics on how to do that. And then key design considerations. So when you are doing interim analysis or sample size reassessment or response adaptive randomization or adaptive enrichment design to get more and more. That's just a graph of that. But this more recent paper in the BMJ gives design considerations for it. So this is, I don't want to go through all of these details because we have a lot.